right, so give me 1 second so I can load this and you can tell me if you see it. Do you see the PowerPoint?
No.
Nope. I'm doing this too well. Do you see it now?
No.
Nope.
Mm-mm.
How about now?
Yes.
Yes.
Okay. Okay. All right. So we're going to cover the medical record chapter first. So I don't know if any of you have ever worked in an office or any area where they've utilized medical records, hard copy. But if you did or do, or in the future do, will, it's not commonplace anymore. They've actually been gone probably 8 or more so years. Have moved to some formal electronic a record utilizing a computer. But if you do, this chapter covers what you might see. In their heyday, they took up a lot of space. Medical records took a lot of real estate, you had to pay for that real estate. But with advances again in technology, we don't have typically a lot of files. But if you do, you're going to need filing shelves, cabinets. There's a variety of type of files, what way you file. Vertical files. What you're looking at, this woman that's in the picture on the slide, she's in a file room utilizing color-coded numbers and letters. These kind of file rooms were really for utilizing a couple of senses. The one thing you'll do an exercise on it over the week, a filing exercise by alphabet. It's one of the worst ways to file when you file by alphabet. People make mistakes all the time. So one of the first things we did was structure filing around a numeric system, and it was color coded. So when you walked into a file room, it actually had the way the numbers, they actually flowed. If you can get up close enough to your screen, you can see, if you follow the files, you'll see the wave pattern of the edges of the files. I have an old one that we used to use in one of our practices. We used to use the color-coded numbers. They were standard. All 4s were always purple, 5s were always black, 6 was yellow, and I don't remember what the rest of the colors were. But these coincided to a certain pattern on the patient's chart, whether this was the first number, the middle number, and the last number. You typically didn't take the whole patient's account number and put it in the color codes because it was expensive. You'd buy rolls of these numbers and it was very expensive. Up at the top, you had the, I'm trying to do this, you have the year. The last time we used these kind of charts was 2011. So this thing's getting a little old, but it's your typical chart where the inside had a couple of sections for x-rays, EKGs, progress notes, miscellaneous notes, and such. But every patient had this type of a file system in place. And it was very commonplace, but expensive because these number stickers were expensive, and you can see them in that picture. Compactable files are similar to what you're looking at with this young woman, but maybe one of the rows at the very end had a large wheel, and you would actually turn it, and the whole row of files would move and compress against the other files. The rationale behind that is because you wanted it to, you want to gain real estate. You didn't want to give up your entire room just to files. So if you actually had a couple of them that actually rolled around, you actually could get more files in the room. Labeling file equipment, that was just what I was telling you about. So you would buy the numbers, and some facilities even used to like to use letters. If they might use the first 2 letters of the patient's last name, along with a couple of certain sequence of the patient's account number, maybe first and second number and very last, but whatever. But each institution, whatever they picked, it was one standard on how you would choose to number the file. That makes sense to everybody?
Yes.
Okay. All right. So obviously with files, and as we talked about before, it's patient information. You don't want them lying around. You got to really protect it and make sure that there's safeguards. The first safeguard you want to do is make sure people can't get into the room that shouldn't get into the room. Maybe you've got a punch code on the door, or in certain individuals have a key. It's okay to leave the door open as long as people are there and can monitor the people that access the area. But at night, you have to lock the door. As I mentioned before in other sessions with you, we had an example where people were putting the charts out the night before, and not thinking that people were coming in and cleaning the offices during the evening, and they had the opportunity to, if they wanted to, rifling through patient information. So you got to make sure that you put processes in place that you safeguard and protect people's files. And make sure individuals are aware of that. All right, let's see. So this is your typical files. This is kind of what I was trying to show you. You have over here the different type of folders. You have hanging folders. So hanging folders are, I don't know if you have maybe a desk in your own home. It's the little folder that has the little hooks on the sides of it, and it drops into a hanging system, and you can file stuff into that folder. That's what they're talking about, a hanging file folder. Binders are binders. This is just what they are. File guides and out guides. So file guides and out guides, let me go back. So where you see this woman in here in the picture, a file guide and an out guide is they don't show any in here, but it's literally a large piece of plastic that literally you would take a patient's file out, and you would put this large piece of plastic in place of it, and then there it would have a little pocket where you could put a little note saying, took out Carol Jones file on May 5th, 2021, or whatever. You would make a little note. The reason you would do the file guides and out guides, 2 reasons. One would be because you want to remember that you took it out, and that if you don't get it back, you know who to call that took it out. And 2, when you go to refile files, nobody likes to refile a bunch of files that are sitting on a desk, but you got to do it. It makes it life easier for you when you go to refile, because you just look for the big plastic out guide that's sticking out. In file sorters, that's, I don't know if you can see where I'm circling. That's this little color thing over here. It looks like an accordion. I don't know if you've ever bought one for school. It opens up like an accordion and it's got a bunch of pockets in it. And that's all they're talking about is for file sorters. Most people don't use those in a business setting, but you might see them in your travels. So filing systems. So you got a variety. You got sequential order. You got alphabetical order. Alphabetical is actually the worst way to file, and you'll find out because you're going to do a competency on that, and it's one of the easiest ones to make mistakes with because you know, I think it's just inherent in people just to misfile things when you're trying to do it alphabetically. You have to follow the filing rules around a name. And we'll talk about that a little bit later when I go over that assignment with you. So you can have reverse chronological order, or some people. And so reverse is going oldest year back, or newest year back. It depends on what you want. If you how you choose to file chronologically, by year. Numeric filing systems. Those are the one I was showing you earlier. They talk about the indirect, the terminal digit and the middle digit. It depends on the organization. So if the patient's, you know, I'm gonna make it up, if the patient's count number was 2243, and you pick the first and last, then you're gonna put the stickers on 2 and 3. And then maybe use letters if you choose to based on the patient name. But the book recommends to use the terminal digit, meaning the last number, and the middle digit. The institution, back in the day when everybody did the files that I showed you, that with the numbers, they made a determination what they wanted. And what they did was their standard. Whatever they picked was what they were going to do moving forward, because you always want to make sure that you're not going to misfile and lose files. Has anybody ever worked in an area where you had a file? No?
Yeah.
Yeah. I think one of there's a few areas that you still see this utilized. You know, this kind of filing system. I see it a lot if you go to the eye doctor, or if you go, some dentists still even use small little charts. And if they're not digitized and they don't have an electronic system, then they're still using some form of filing system. And a lot of them still use it, and they'll use the little number system. So this shows you a picture of the color coding. You know, you would choose, again, the organization would choose whether or not they wanted to use letters. You always use numbers, but you would choose if you wanted to do letters. Supplemental files, those can be for anything, you know, depending on what you want to file. You know, some people like to file referrals, you know, and as patients are, you know, coming in the month of June, they'll stick all the June referrals in a folder. They don't even file them by name. They just stick the referrals in. Some people will do different ways of filing patient information, but it's a supplemental. It's more than, you know, essentially you need to do. A tickler file. So what a tickler file is, it's a file that cues you that something's coming. So you can have a tickler file that's electronic, or you can have one that's manual. And so a real good example of a tickler file would be yearly physicals. So, you know, you were seen by your doctor this June, and your doctor wants to see you again next year for your physical again in June of 2021. Typically what's going to happen, the office will file some, probably, I'll make it up, say your appointment's for June 15th, 2021. They're going to file something May 15th, 2021, and it's the tickler file, and it's going to remind the staff, oh, she's coming in next month. We need to send her a reminder. We need to make sure that, you know, nothing's changed, that the doctor hasn't taken that day for a vacation day or whatever. But that's really what a tickler file is. It can also be electronic. So you know, most of us, when we book dental cleanings every 6 months or yearly physicals. Right about a month before it's going to happen, something happens to cue whether you get a text message or not. So they expect that you're going to do some steps in the filing process. Just want to make sure nobody's waiting. There we go. They want to make sure you inspect your release, you check for the conditioning, make sure that nothing needs to be fixed. Indexing, make sure you're cross-referencing, looking at the codes, making sure they're correct, that you pick the right numbers, that you're sorting them correctly, that you're filing correctly, storing them. Are they, files are really important that you store in a controlled area. It should be fireproof. It should not fireproof. It should be have sprinkler systems and have some kind of environmental system, whether it's air conditioning and heat or whatever throughout the year. You can at certain points of the year do what they call purging, because you can't keep all your files on site forever. So sometimes you have to take your oldest ones, box them up, and then send them off to a local site somewhere, in not a factory. Blank. I can't think of the word I want to say. I'm sorry?
Storage container?
Yeah, a storage containment facility, but it's got to be, it can't be like, exposed to the elements. It's got to have heat. It's got to have air conditioning. But you're paying for just to leave boxes there. So, and at some point in time, and so you got to make sure you label those boxes correctly and what the files are that are in the boxes, because if the patient shows up 2 years later and you got to retrieve that file, you got to be able to easily go into that facility and retrieve it. Filing guidelines, you got to check it every time it's pulled, make sure it's in good condition. Don't force or crowd the document or folders, because what'll end up happening is the numbers and letters come off the file, and then either replacing them, or it can result in you possibly losing a file down the road. You don't want to, file rooms are for file rooms. You shouldn't be sharing it to store equipment or any kind of patient-related items. And locating misplaced files. So that's important. When you lose a file, you have got to make every effort to find that file. And if you can't, you need to notify the patient that their file has been lost, and you have to try to the best of your ability to recreate the file. And that requires that you reach out to any physicians that you referred the patient to, any facilities that you referred the patient to get copies of the records, because it is your responsibility to do the best you can to recreate the file to the best of your ability. You just can't say, oh, I'm sorry, we lost your file. But you do have to be honest should you misplace a file. Typically, in the day when we had files, the first place I shouldn't say I was awful. I was the person you didn't want in a file room. People in a file room should know what they're doing. It is a true skill, and again, like people that did the color coding system back 10 years ago, they could go into a file room and they could spot a misplaced file immediately. They could see that somebody put it in the wrong area, because they were more attuned to the color than they were to the numbers, because they could see how they were flowing. The numbers would flow along the shelf. But if you lost a file, the first place you always go to look at a misplaced file is a physician's desk. It never fails. At the end of the day, you would go in their office and they'd have 5 or 6 files sitting on top of their desk. So it was your first, but you have to do the best you can to try and recreate a file. So here's our different type of files. An active file is one that's obviously it's used frequently. Those are patients that probably come in about every 6 months to a year. If somebody is not in within a year or better, their files are at risk to be purged, and that means, you know, being put off to a remote facility. And those would be what we would call an inactive file. It's used infrequently. A closed file is means just that. It's the patient has moved, we've sent it off, or we haven't seen the patient in 10 years. There are rules on how long you have to keep files, and they vary state to state, but most are 7 to 10 years. So it is our responsibility to prove that we've managed them. If a doctor's office chooses, or if a doctor chooses to retire, there's rules and regulations around what they have to do with those files. They just can't just discard them. They have to appropriately send them to either back to the patient, notify you that your file is, you know, needs to be picked up, or offer to have them. You can do two things. You can send them, if a doctor is going to take over the practice, you can offer that you stay with that doctor, or you can ask that they are transferred to another physician. Okay. When a doctor closes their practice, they don't really sell the medical records. That's like slavery. You can't do that. You can't sell people's lives. So you have to let them have the choice if they want to stay with the practice. It does, to some degree, have a monetary amount to it. You know, if you're selling a building, you might see the real estate component to it. You know, a building that has a bunch of doctor's offices versus a building that doesn't. The amount of money each generates could be very different, but it cannot play in the actual patient files. Retention schedule, that again, that's gonna depend on where you live, the state you live in, the government, and what you do. You know, some files like PDs, they feel like you got them forever because you got to keep them in some states between the ages of 18 and 21. So that can feel like you're going to have those files forever. I think mammograms were also another one when they were on film. You had to hold on to them for a long time too. You couldn't just get rid of them after 10 years. So there was a lot of rules around different ones. Storage facilities, that we talked about that. You got to pay them to keep them there, and they have to honor and say that they're going to take good care of them. All right, so that's that chapter. Any questions on that one? Now, can you see the next one, 14?
Mhm.
Good. All right. All right, so telephone technique. This isn't long, it's pretty quick. So I don't know if you've ever had the opportunity to work with a telephone system. There's a variety of things that you can do with them. You know, you can have multi-line phones. You know, when you're utilizing multi-line phones, so it's really important before you move one caller or you can't take another caller, you have to ask that first caller, can I put you on hold? Is this an emergency? Never just put a person on hold, you know, to answer the phone and say, please hold, and then put them on hold, because you have no idea what's going on with that patient. That's really poor telephone etiquette. Always say to the patient, you know, Mrs. Jones, I'm going to put you on hold and I will get back to you in a moment. Is this an emergency? And if they say no, and they say, then you just let them know, okay, I'll be right back with you as soon as I finish with the first caller. But there's obviously telephone etiquette. So we got a variety of things. Call routing. So call routing is literally moving you might think you're calling the front desk of an office, but nobody's sitting there, so they routed their phone number to the back of the office. It's just simply moving one number to another. I think you can even do cell phones today. Voicemail and office phone mail, that is what it is. It's voicemail. Somebody calls, and I'm sure most of you have done it. You've called the office and you're talking to somebody, and then you just tell them you're talking to an answering machine, and you leave your message. The rules around voicemail in healthcare are pretty explicit. So there's an expectation that you get a call within a reasonable amount of time. So if people in healthcare utilize voicemail and voice messaging in their pools, there's an expectation on the callback. Answering machines aren't really commonplace anymore. I haven't seen one in a long time, but I guess they could exist. So they're out there. God, I would hope not with tape. Years ago, they used to have little cassette tapes in them, but I'm sure there are some answering machines. Well, I guess some home phones you can buy with an answering machine on them, but they're not commonplace. Answering services are commonplace, and they will be something that you will work with in the healthcare environment. So you will work with an answering service in the healthcare environment. We utilize a company called Crocker. And so what happens is after 5 o'clock or 5:30, when everybody's getting ready to leave, the last person moves the phones over to the answering service. They're the people that you call, and I'm sure maybe some of you have kids, and you've called your pediatric office and you call them on a Saturday. You're getting the answering service. The practice is paying them to cover calls. So that's what you're dealing with. You're dealing with a third party who's trying to contact the doctor for you, but you have to have some form of answering service after hours. So if your operations are 8 to 5, Monday through Friday, every day from 5 o'clock, you got to transfer your phones over until 8 o'clock the next morning to an answering service, and then for the weekends as well. Cell phones and personal and business use. I think I mentioned to you before that cell phones are really becoming commonplace, and the problem with them the problem with them in the healthcare arena is, at first we didn't want people using their phones, and we kept telling everybody, put your phone away, put your phone away. Now what's happening is there's a lot of technology that's coming out that suddenly we want everybody to download these apps and put different things on their phones because we use it to communicate with each other and with physicians. The problem with that is it's your personal device, so it can lead to some challenging conversations, because we're telling you we don't want you sitting there texting your family and friends and looking at whatever, YouTube or looking at a Facebook or whatever. It contradicts what we're asking to do to utilize a device. So I wouldn't be surprised probably within the next 5 years, it'll be commonplace for you to go to work and somebody's going to hand you a cell phone device, and you're going to utilize that for your work day rather than use your own personal device. And I actually think that's better, because we should not have control of your lives, because at the end of the day, the minute you start downloading apps onto your own phone, be it that they be whatever they are, you're kind of tied to work all the time, because people don't know that you're not there. They'll be sending you protected text messages or whatever through these apps. I wouldn't be surprised. I think we're going to probably see more usage with cell phones in the future, because technology is moving faster than we can move along with it. Pagers. So I'm old school. I still use a pager. I have a pager that it beeps and leaves a phone number for me to call back, but it also sends a message to my phone. I can't give it up. Many people I work with don't carry one. I still carry mine. Maybe one day I'll be able to let it go. But paging is actually not a protected mechanism for HIPAA, because for some reason it goes over a certain airwave that is not as protected as a cell phone. So they're looking at pagers as, and I wouldn't be surprised if they become totally obsolete. Telecommunication devices, TDD devices. I don't know if you've ever seen one of them. They show you a picture in the PowerPoint here with this guy over here. Essentially, it looks like a laptop. And what it offers the patients that are deaf, it offers them the ability to see somebody and actually be able to see their face. Reading lips is really hard. It's not the easiest thing, but they can at least see somebody doing sign language if they know sign language. So it's really a device that allows the deaf to for better for us communicate. And it's like a telephone, but but it's for the deaf. They're able to visually see the person. It's like FaceTime for better for worse. Communication. So from the time we're all little kids, we're all taught to say please and thank you. But communication skills, it kind of ties back to telephone communication as well. You want to make sure that when you're having a conversation with a patient or a coworker or anybody on the phone, that the story is complete, that you're speaking clearly, that you're focused, that you're being concise, getting to the point. Don't be all over the place. That you're being courteous. You can tell when somebody's not genuine. I don't know how many of you have had a conversation with somebody on the phone, whether they're a telemarketer or anybody. You can tell when somebody suddenly changes their tone in their voice. It's in the flexure in their voice. And most of us have done it, and you kind of give it right back because you're realizing that they're not being genuine and actually they're being somewhat sarcastic. And usually most of us, when we get caught doing that on the phone, you course correct. If you start off with courtesy and being respectful, you're typically going to get the same response back from the other person. And I think I went over the guidelines for using the phone effectively. That you have to always make sure that the patient has the opportunity to end the call. You never put anybody on hold without asking them first if it's an emergency. You always let the patient end the call. Ask them at the very end, have I answered all your questions? Is there anything else I can help you with? And of course, follow HIPAA guidelines. So as we mentioned before, you can't, you have to be very careful when you call with patient information on the phone. You typically don't know who you're talking to. If you call directly to somebody's house and they say that they are Mrs. Jones, you have to trust the fact that somebody in that household is truly Mrs. Jones and they're not lying. So you're protected in that instance. Where you're not protected is if the patient calls you. So if people call the office and they say they want somebody's information, you don't readily give that information out. Or if you call and leave a message as somebody's employer, you never can leave that information. You can leave the message that the physician's office has called, and if they want to call, please call when they have the time. Okay, so you always have to protect the patient, your confidentiality. Your telephone voice, you got to be able to, pronunciate and enunciate. And again, we talked about tone. Tone is really important because every one of us can very quickly, especially on the phone, you would think you need all your senses functioning at once, and you don't. Most of us can very quickly pick up when somebody is not being authentic, and that they have an edge to them, or they're being sarcastic. Most of us can pick that up right away. It is your time to make a good impression. Even if the caller's angry, there's typical reasons. We've all been there. Maybe somebody got a bill and they're upset because they were told that it wasn't going to be a charge. Whatever the reason, always be courteous and give them your undivided attention. The minute you deviate from those simple processes, you'll see it, your relationship on that call will really it'll dissolve pretty fast. So always be courteous, always give them your undivided attention, always make sure that they get the last word. We talked about putting the call on hold. They need to know first that you're doing it and that's not an emergency. Returning patient calls, those are rules around that. So if a patient calls and they need their medication, their meds renewed, or whatever it is, you have to call them back within a reasonable amount of time. And most offices set up standards that they expect staff to meet. If they're calling, I need copies of my child's medical records for starting preschool, and you're in the middle of June, that's not critical. But if somebody's calling saying, my insulin is out and I need to order more insulin or insulin syringes, you need to do it within a reasonable period of time and let the patient know. Remembering patient names, that's really important. So it's like family. So when somebody's, and I would remember them by their last name, unless they tell you that you can call them by their first name. Always refer to somebody as Mr. or Mrs. or Miss or whatever their last name is. But unless again they tell you can freely call them by their first name. Communicate with empathy. Maybe a patient's calling all upset about a bill, and it's real. The bill is real. They didn't understand their insurance. Everything was clearly explained to them. The bill was $400, and it is what it is, and we're not going to change that. Having an attitude with that patient is not going to help. You want to be empathetic. Gene, Mrs. Jones, I know that's a lot. But the office did communicate with that to communicate that information to you. Let me see if I can send you to the billing office, and maybe they can come up with a way to help you pay this. Maybe you can make a payment plan. You want to approach it with some kind of empathy and understanding that we don't know what's going on in their lives. We don't know if they're in a tough patch right now and they're not working or whatever. So always take that stance that, gee, this could be my mom or my dad or my sister or my brother, and it's happening to them. You want to make sure somebody understands it and tries to help them solve with some kind of a solution. Ending the conversation, again, that's the patient ends the conversation. Always ask those simple questions. Have I answered all your questions? Is there anything else I can do for you? So we're going to get a variety of calls from patients, appointment scheduling. Typically those are done through, if you're in a large office, there's probably a service that does that for you, because they typically can do it better and take and manage a lot heavier calls than a small office can. If you work for a small doctor's office, it's kind of a chief cook and bottle shop. Everybody does everything in the office. But if you work in a big practice, a lot of things get outsourced. Billing gets outsourced, appointment scheduling gets outsourced, because when you have large groups of people doing one specialty, they're actually more efficient. Requests for reports, that's what I was saying earlier. Patients might call and say, hey, I need a copy of my child's files for, to start kindergarten or preschool or whatever. Or they're calling looking for reports because they want to go see another physician and bring the report with them. So you got to make sure you're handling those incoming calls and you're reacting to them each appropriately in a timely fashion based on the need. Questions around medications or care, those are medical pools. Those should be always addressed by a nurse. Medical assistants can look at them and help triage them, but the nurses typically will manage those pools. You have the other calls. You got attorneys that call. Attorneys should be held to some level of control. You don't just let them go to the back office if they call saying they want to talk to the doctor. You don't let them just talk to the doctor. So what you do is take their information, and then you'll have somebody call them back, whether the office manager calls them back or the physician on duty. Attorneys don't get free carte blanche to the back office. Other physicians. So this is a how do you say it? This is a physician respect to another physician. Physicians they never want to be interrupted while they're with a patient. The only interruption a physician will take when they're in an exam room is if a physician calls and they want to speak to them. That's like a respect thing that they have for one another. So they'll leave you, the patient, for a moment and just apologize for that they need to leave to speak to somebody, but they will go speak to another physician. They won't say, oh, just tell them I'll call them back. They'll get up and they'll go and speak to that physician. It's a collegial thing that they'll do for one another. Salespeople, they get stopped at the front, and they don't make it past the front unless somebody comes out and gets them. They're an interesting breed because they're trying to make a sale. We need them. Many of the things that they bring into the office we need, but they try and manipulate staff, and they like to get behind the desk to get into the office because it's hard. They live on commission, most of them, and they'll do anything to make a sale. So if anything they can do to get behind the office desk and get in the back area to encourage whether they're physicians or anybody to purchase their product or whatever, they'll try and do it. But they should be stopped at the front, asked to have a seat. And honestly, if they didn't have an appointment, I'm not in favor of even bringing them in. So that's my take on salespeople. You got to screen your calls. Obviously, you're going to route them to all the appropriate areas. If calls are coming in around meds, you're going to send them to a med pool. If you're getting a lot of calls looking for reports or looking for printing files, that goes to an administrative pool where the admin staff might take care of it. And that's just what you're going to do. Some people manage those calls all day long, and they'll triage what bucket they need to go in. And the same thing holds true for, they mentioned it again. So telephone triage is the same thing. It's the screening calls. But those could be coming from a contact center. So remember in the beginning, we were talking about a facility might be scheduling all of our appointments. So if they have problems or they have questions, they might send some messages into our direct office saying, we got a call for a patient that needs to see Susie Jones, Dr. Jones, in 2 weeks, but we only have the soonest appointment we have is 4 weeks from now. What do you want us to do? So they might call into one of these triage numbers, and they'll wait for a response back from us on when we need to or when we can try and meet that patient's needs. Documentation. So the MAs, you guys probably have heard this 100 times. If you didn't write it down, and if it's not there, or it's not in the electronic record, it didn't happen. You can say over and over and over again, I told the patient this, I told them. If you didn't write it down and document it, it didn't happen. So same thing holds true for phone calls and messages. You gotta write it down. If you work in a place that has pads, you gotta write it on a pad. And there's rules around documentation because you can't erase, even on a pad at the front desk. Even if somebody uses a pad for scheduling, or a scheduling book that you write in by hand, you never ever erase. You can cross out, and then you can initial, with your initials and the date, and then put in what needed to be there or what patient is going to be rebooked in there. But you never erase, because in a court of law, it'll actually come to your benefit if a patient no-shows, 3 or 4 times over a period of a couple of weeks, and then all of a sudden they're coming at us with a court case saying that they have a massive infection in their leg because we didn't take care of them. We can at least go go to the our own attorney and say, well, we actually do have proof that, you know, it's the patient's fault. We try to call the patient, we kept rescheduling the patient, and they kept no showing. So we, you know, but if you have no documentation that they never came for your appointment, you have no documentation that they called, it puts you at risk. One of the nice features about phone centers, big phone centers, typically not your own office, but if you partner with a large phone center that does all your scheduling, they typically record all their calls. So if patients call and insist, oh I called, there's a way for them to track it, and it's legal in a court of law if we can prove that no, the patient never called. We have no record, we have nothing that shows that they called. So so that's our electronic messaging tips. And obviously we're going to maintain patient confidentiality. You know, we're not going to call patients. We're not going to leave messages to patients calling us. It's a different story if you do call patients at home. And again, if somebody answers the phone and you ask for John Jones and he says, hi, this is John, you have to trust, there has to be a level of trust that wherever John lives, the people living in his household would be respectful and not say they were John. So we are protected to do that and give those results out. But if somebody's calling you directly, you have to be very careful because you don't really know who they are. Placing outgoing calls, you obviously got to know where the telephone numbers are. Many areas, many facilities too also have long distance access depending on the staff. You got to be careful of that. We had a few years back, one of my areas had a huge phone bill that kept coming in from the Ukraine. I was approached by one of the finance officers saying, you know, we're seeing these hefty phone bills coming from one of your areas, but they're coming from late at night. So we looked at the phone bill. You know, I couldn't understand why we were seeing such big bills, and it was all coming from the Ukraine, which is just outside of Russia. I'm going to kill my dog. I don't know if you can hear that dog. So these bills were coming right outside of Russia. So when we looked into this, it was our cleaning people. So they figured out how to make a long distance call. They learned that if they hit 9, they could call anywhere they wanted. So we had to work with the phone company to disengage that at certain points in the day. But you know, there needs to be the knowledge by the team that you have certain phones maybe that can make a long distance call and others that might not be able to. But you got to be able to let people understand how they can make calls and where they can make them from within the office. Retrieving messages from the answering service. So at the beginning of the day, first coming in, you're going to connect with the answering service that have been answering your calls from 5 p.m. till 8 a.m. and get feedback from them. Because some people might, depending on the emergency, they might not have reached out to the physician during the night. So if somebody called the answering service at 4 in the morning, if the answering service felt that it wasn't an emergency, they might say to the patient, I'm going to have the office call you at 8 in the morning. That would be an example of retrieving a message from that service. Arranging conference calls, that's really an admin support help. That's trying to get people together. Like I might have a conference call where I want to have a call with all my managers. So it's just a variety of people calling into kind of like a Zoom meeting. They call into a generic number and they join the call. Okay, so that's it for that. I hope you're still awake. So those are the 2 chapters for this week. I'm going to be releasing the SimChart exercises, and I got 2 of them I'm going to release tonight for you. One is on page 165. So you're going to document allergies and medications for Ella Rainwater. Okay, so that's on 165. And then the next one you're going to do is on page 287. And this will be the first time you're going to post a payment to a ledger, and you're going to submit a claim for Al Navassier. So you've now scheduled a patient. So you've given them a schedule. You've created a matrix, so we know when physicians are there or aren't there. You've scheduled some. I think you scheduled somebody for rehab. So now we're getting money. We're going to get some money back. Or I apologize. We're going to post a payment. So the ledger. So a ledger is the accounting of the patient's care as how it relates to the finances over time. So the ledger is not a one-time view. Unfortunately, SimChart typically makes it look like it's a one-time view, but it really isn't. The ledger can always have a balance. So if you see the doctor over a period of a couple of months, and if you still have a balance of $50, and then you see the doctor again, and then they bill you again for another copay, and you didn't have the money, I don't know. Okay, so what the ledger is, it is actually the continuation of your bill. So you might have a balance, and then you see the doctor again, then they're going to add that balance in. Then if you give the doctor $30, then they're going to take $30 off the balance, but you'll continue to always have a balance until you have a zero balance. That's what your ledger is. I don't know if you've ever seen like something like you might get from one of your doctor's offices, or like a credit card for that matter, because a credit card really bill is like a ledger too. It's just a continuation of charges and payments. SimChart is very rudimentary. So when it shows the ledger, you're going to create the ledger, and it's always as if the patient has a zero balance. So it's not as real, for a better word, but that's what the ledger is. You're also going to submit a claim for Al to the insurance company. So Al is getting a flu shot, and he gets a flu shot. And he pays his copay, and so you'll be showing that as well. And you're going to use his super bill to update his claim in ledger. The super bill is actually it can be called an encounter form or a super bill. And you'll see what it looks like when you start this. And we're actually going to do a one by hand too in a couple of weeks. I think next week. The super bill is actually the form that maybe some of you have seen when you go get blood work done or something, where the doctor checks off on the form what they want you to have done. It for better word, it drives the charges. In the claim form, you'll see actually in the claim form and in the super bill, you'll see the charges. So when you do this one, the one on page 287, I want you to go slow, because it's the first time you're going to see these, and you're going to actually be going into that third tab, the billing tab. You've been kind of just living in that first one. And I don't know if I don't think we've really done too much documentation in the second tab in SimChart. That's your documentation tab. So go slowly through here. It will ask you to go to, it's going to bounce to the internet. So if you look at page 287, the bottom of page 287, you'll see the thing where it says, I don't know if you can see it if you're looking at your book or not, but it says the true code. So that little thing over on the right, when you type in I'm going to make it up. Let's say it's chest pain. You type in chest pain and then click on the true code. For the coders, what it does, it jumps out to the internet and it looks up chest pain for a CPT code. The CPT code for chest pain. It's all it is doing the exercise to tell you what the CPT code is if you did that exercise. It literally, though, in the measurable steps, does give you the actual CPT code as you move along through the numbers, through the measurable steps. They use the word POS in here, and they don't really explain, but POS means place of service. Okay, so if you see POS, they'll say like, our POS number is 11. All it means is number 11 to the insurance company means our place of service. Okay, but I want you to go slowly on this one because this one's a little more involved because you're going to be again posting some money to his ledger. Okay, any questions?
No.
Okay. All right, and the last thing I want to talk about, so we did the filing chapter. Now what I want you to do, and I'm going to release it, you don't have to do it right away, but I'm going to release the assignment that's in the weekly units at the bottom. You'll see it says filing exercise. It's all it is a competency. You get 3 tries to try and file the patient's names in alphabetical order. They're in an incorrect order, and then you're going to number them what they should be correctly. When you file patients by name, you always file by last name, first name, middle initial, and then if all those factors are the same, then you go to, do they have any kind of a surname? Are they a physician? Are they a priest, a nun? Do they have anything at the end of their name that we can try and make them distinguishable from somebody else? Sometimes if they have nothing, you might have to work with that patient and say, we're got to put a number 1 after your first name, because you got to somehow distinguish the patients by their name. So in the exercise, you'll also see that there's some saints. So there's like a Saint John, and his name's spelled S-T and then J-O-H-N, and then somebody's name is Saint John, but it's S-A-I-N-T. You don't change what those are. So the one that would be filed first is the one that actually goes S-A, because the S and the A come before an S and a T. So take your time when you're looking at the list. The exercise is really there to show you that it's a challenge to file by alphabet, and it's not really the best way for any of us to file. Actually, I think it's one of the worst ways, because if you're going to misfile, if you file by alphabet, it's the best way to lose a file. All right, so that is that, and I will release it. And again, you'll have 3 tries to get 100 on that. That's about all I got tonight. I don't know if anybody has any questions. How are you doing? Is everybody feeling pretty good?
Yeah. Yes. Sure.
Okay. All right. This will probably be a little more challenging, this assignment tonight, the one for Al. But if you go slow, if you get confused as you're going through it, shoot me an email and I'll see if I can help and explain it a little better. Okay. But
Sure.
I think everybody's doing pretty reasonably well. I went through and I graded all the SimChart exercises. I know somebody tried to email me a printed document. You don't have to print any document. So if something in SimChart says, print this or print that, ignore it. Okay. Because I can go in and look at everything that you saved within the SimChart. So save your paper. You don't have to send that to me. If you haven't done your block style letter and your vendor exercise, don't hang on to those too long either. So keep on track. But that's all I got. Have a great weekend. If you got no questions,
You too.
I'll try to make sure I send this out so you can, if somebody wants to go through the torture of listening to it all over again. All right. Have a good weekend.
You too.
You too.
Thank you.
Bye.